I'll start with this 71-year-old female who is hypertensive, had bilateral knee replacement in February 2023. June 2024, slipped and fell. And then she had a periprosthetic fracture. And these were the x-rays. And you can decide whether you want to do fixation, which is quite unlikely here, or revision, or if there's a preferred implant. So we'll come back to this. Start by saying that the projections of primary and revision hip and knee replacement show a large increase in the incidence in the numbers. And when we deal with the bone defect, we want to fill in the defect, support fixation of prosthesis, and facilitate the load transfer. And the zonal fixation concept says that you should have purchase in at least 2 of the 3 zones. And initially in the past, when only the stems were used to overcome these metaphyseal defects, either by cemented or cementless stems, they were huge failures, 18% to 22% at 3 to 4 years. So why metaphyseal fixation? Because metaphyseal cones and sleeves fill the bone defects, allow loading of the metaphysis, reducing the stress shielding, and provide greater rotational stability compared to diaphyseal fixation alone. And this is a good article to give you the brass tacks and the important principles. So let's talk about these options which target zone 2. So the sleeves, they provide you fixation and augmentation. So they provide you direct fixation, which can be cementless, and the cones give you augmentation only with indirect fixation, where the defect is filled with the cone before implant fixation with the cement. So we'll start with the sleeve. It fixes the zone 2, made up of titanium, 50 to 80% porosity, more taper fixation, so no cement is required, axially and rotationally stable, bone on growth occurs. It provides a new level of immediate fixation, manages severe bone loss, provides stability of construct, allows controlling flexion gap and joint line, and then allows uncemented fixation. Now the advantages of sleeves are shorter operative time, it's really very quick, reproducible technique, and transferring loads to the intact host bone. However, there are problems with removal. Fracture during implantation is a real issue, junctional failure, lack of offset adjustability, and implant system cross compatibility. Survival reported to be 92.2% in these papers. Another paper, 6.4 years, 100% survivorship of the metaphyseal sleeves, and you can even use them without stem, particularly if it is the type 1 or type 2 AORI defects. It's only in uncontained defects and type 3 defects that you may have to use this stem. So it doesn't matter if you can't get a stem in because of the abnormality of canal or non-availability of the offset stems. Now there are custom sleeves also, which is called beyond AORI 3 defects, which means going deeper towards the diaphysis. So that's what you see. The 4 on the left are actually the rasps, and then what you see, the 5th one, the long one, is really the implant. Then coming to the cones can be coupled as a part of the implant, or they can be uncoupled. This is titanium by Stryker, which allows the surface bone integration, whereas the trabecular metal by Zimmer does the bone substitution. And these are the different types of cones. You can choose the one which suits you or for your purpose and bone defect. And there is not much of a difference between any of these. If you look at them, really, they are all alike. You could use anyone which you like. The difference just being subtle difference in the pore size or coefficient of friction. Now, what are the advantages of cones? The cones allow you fixation independent of the stem. You can interchange between the systems and manufacturers. It doesn't matter. You don't have to use the implant from the same company as the cone. And then in larger defects, there are improved outcomes with the cones. So the indications for cones are extensive lysis, sclerotic bone in zone 1, any prior stems, young patients, hinges, and reimplantation with the poor diaphyseal bone. And these are custom cones, just like the custom sleeves you saw, 3D printed ones. So if whatever philosophy you prescribe to, there are chances of customization or opportunities there. Just taking you through a quick case, a preoperative case of a failed IB2 here, preoperative pictures and the implant removal that has been shown so elegantly by Manoj. So you start preparing the tibia, have a trial, just like Anil said, you just do your trial without bothering about the bone defect, and then you start preparing for the bone defect, burring, implant placement, trial placement, implant placement, and then you can cement the implant in place, and this is what it looks like. Now, the survivorship of cones is very good. 10-year survivorship at 81 years, and with aseptic loosening, it's 96%. Another paper, 95% survival for trabecular metal cones, and another paper, the 10-year survivorship was 97%. The most common cause for revision was prosthetic joint infection, instability, and aseptic femoral component loosening. There are good techniques. You can just do freehand preparation for these with good results. And if you are using if you are addressing the tibial defects, the tibial sleeves fare less favorably than the cones. So the tibial sleeves show less survivorship as compared to cones when it comes to the proximal tibial defect. And if you try to fix them with the hybrid technique, again the sleeves are inferior to the cones. Now, this is another paper which shows the comparison between the cones and sleeves, and you can see the aseptic loosening, periprosthetic joint infection, and revision rates are higher in cone in this particular study, even when the clinical scores are the same, which is both at short term at 12 months and long term at 60 months. Another paper, revision-free survival for cones is 91.3% and 92% for the sleeves at 41 months. Another paper saying metaphyseal, another issue is that the metaphyseal cone can be combined with offset stem and short tibial stems, whereas that opportunity is not available, option is not available with the sleeves. The infections have been reported to be higher with the cones, and survivorship is in this particular paper comparable, but the commonest failure was because of the prosthetic joint infection. Another paper confirming no difference between the survivorship, but the revision rate for any reason for femur or tibia sleeve was lower compared to cones. Another paper, no difference in survivorship, but revision rate for cones was higher. So consistently, a message keeps on coming up. The extraction may be somewhat easier for sleeves as compared to the cones, and various techniques have been described for the same. Now, there has been meta-analysis by authors including Dr. Ashok Raj Gopal, which says in young patients, the bone graft with least constant implant should be preferred. And this is our publication of distal tibial metaphyseal allograft for the metaphyseal defect, used much like a cone successfully in a young patient. So coming back to our patient, this is what we did, took out the implant, this was the implant, and then prepared it, and prepared for the sleeve, used a sleeve, and this is the real definitive sleeve and the tibia, and this is the check X-ray, and you can see the principle of sleeve where it allows the augmentation as well as fixation. The sleeve has crossed the fracture and is actually giving fixation distal to the fracture in the diaphysis. Also, just another 30 seconds. And these are the fluoroscopy images, X-ray. This is the patient at the time of stitch removal, and this is the follow-up X-ray. So the meta-diaphyseal fixation, reduced mechanical stress, and use of high constraint is possible with both. Stem augmentation is not needed with sleeve always. It's needed with cones. Offset stems are not available with sleeves. Cement fixation is not needed in sleeves, but is needed in cones. Size limitation and need for bone shaping giving rise to loss of more bone is required for cones, not for sleeve. Osteointegration is slower in sleeves. Intraoperative fractures can occur in sleeves. Risk of PGI is more in tantalum cones. Ease of removal and use in uncontained defect are the advantages with titanium sleeve. And this is some of the recommended reading in case you are interested. So conclusion is you must understand the zonal fixation. Both sleeves and cones have got implant survivorship exceeding 90%. Cones show higher complication rates in short and long term compared to sleeves. Tibial sleeves have a higher risk of revision compared to tibial cones. High risk rates of PGI in cones compared to sleeves, but then the jury is still out. You can take your pick. Thank you very much for your attention.